Welcome to Decoding Healthcare Research. I'm your host, Efrain Riveros, Dr. E. Efrain. Today we are here to talk about obesity. Obesity from different perspectives. And we have an expert with us, and it's an honor for me to have Dr. Beenish Masood. She is a researcher of diabetes and endocrinology at the Royal Free Hospital in London, UK. She has vast experience in research, and we are going to discuss here and share some thoughts. So first of all, I want to welcome Dr. Masood.
Thank you, Dr. Rain.
Perfect.
Hello.
Thank you. I'm sorry, go ahead.
Sorry, I just wanted to clarify that I was working as a researcher at Barts Health Trust prior to my current post, and I'm working as a clinical teaching fellow at the Royal Free Hospital at the moment.
Okay, that's perfect. So it's two institutions involved in your research, and that is awesome. So I think that obesity has become a very important topic everywhere. So you turn on your TV and everybody's talking about the epidemics of obesity. Everybody's interested in learning about the different causes of obesity and what we can do to improve at the individual and also the societal level. So
Yes.
first of all, we were actually talking offline with Dr. Masood, and she was telling me about how she started doing research in this important aspect and what is her background. I want you to start telling us a little bit about that.
Right, thank you. So I've completed my undergraduate degree in medicine from Pakistan, and then I completed my training in general medicine from there as well. So I'm a consultant physician in medicine. Then I came here to the UK. I pursued Masters in Clinical Endocrinology from the Queen Mary University of London, and I did my dissertation in genetic obesity. That's what sparked my interest in obesity. And then I continued working at Barts Hospital, which is affiliated with the Queen Mary University of London, to pursue obesity, clinical obesity research. And that's the time during which I wrote this article that Dr. Rain has kindly mentioned.
Excellent, and I feel that that perspective of genetics in obesity sheds like a light on new aspects, right? Obesity goes
Absolutely.
goes beyond a caloric imbalance, and we are going to discuss that. So you mentioned
Absolutely.
that genetic obesity is like your focus. So I want you to tell me a little bit more about that. How is genetics uh, involved in this process of metabolic dysfunction?
So basically, the actual purely genetic causes of obesity, which we call monogenic obesity or single gene mutations leading to obesity, are not very common. Only 5% of severe early onset obesity basically is because of monogenic obesity. But that 5% is so severe that it is a life-changing disorder for the parents as well as the patients who are diagnosed in young age, of course. There is something we call hyperphagia, which is essentially hunger, which is insatiable. So they are eating out of the dustbins, they are eating at night, they are eating anything they can get their hands on. And it's a real challenge because the minute the child becomes independent and of course the parent can't control what they eat, they just put on massive amounts of weight, and they go up to BMIs of 45, 50, even 60. That so basically the research started because there's now a drug that's being developed for these kind of disorders which involve the melanocortin 4 receptor, that's we call it the MC4R receptor. And there's a drug that has been now developed and is being used to treat these kind of obesity. So during my dissertation, we were screening for genetic obesity in the young adults who were presenting with obesity at our clinic. And it was interesting that we found that while there were some mutations in about, I think, even 70% of the people. So we screened about 40 patients, and only 30 to 40% didn't have any mutations. But the interesting thing was that the mutations that we found, they were non homozygous, so they were heterozygous, and they were not found to be directly associated with obesity research. So they were in the pathway of the melanocortin 4 receptor, but they were not found to be directly associated with it. So there is one thing that, yes, some genes are associated with it. And then there is another thing that a lot of genes may be found to be mutated in these people, but they're not pathogenic for the obesity. So that's something that we can probably attribute to polygenic obesity, where little factors lead on to you gaining weight. So there's monogenic obesity, that's single gene disorders. Then there's polygenic obesity, where multiple genes and multiple factors can cause you to gain weight. And then there is syndromic obesity, which is basically monogenic obesity with some syndromes. So I would say that it is probably when for people who have it, it is a very big problem, but it is not responsible for the majority of obesity that we have today.
Yeah, so when we think of obesity only caused by genetic factors, as you say, it's very rare. But at the same time, I assume it sheds some light in terms of mechanistic effects, and it helps us understand better what may be underlying obesity in other populations, right?
Absolutely. So for monogenic obesity, basically, there's been found that the pathway that controls food intake, so we call it the leptin melanocortin pathway, it is basically an interaction between signals released from our adipocytes. So fat cells release a hormone or a chemical, if you like to call it, called leptin. That ideally is a messenger that goes to our brain, and specifically neurons in the arcuate nucleus, that we call it, part in the brain, which has two types of neurons. So the one type of neurons are stimulated by leptin, and they basically cause the person to feel full and not eat anymore. And another part of the neurons are basically inhibited, and they basically cause us to eat more. So we call them orexigenic and anorexigenic neurons. So I'm not using technical terms not to make it confusing. But if you, so the mechanism has been linked by one researcher as a kind of like an accelerator and a brake response. And so this leptin basically, along with a lot of other hormones, it basically affects our food intake. And what happens in people who gain weight because of whatever reason, and they have a higher number of fat cells, and a higher number of fat cells secretes more leptin. And what happens is, much like insulin resistance, this leptin resistance then leads the person to becoming basically unable to respond to signals, to leptin signals. So they just don't know when to stop eating, because the leptin is unable to communicate that, look, you need to stop eating now. And that is what leads the hunger drive. Now, the while leptin may drive the overeating in people with non-genetic obesity, it was discovered when monogenic obesity which caused basically monogenic obesity caused by leptin deficiency and leptin resistance was discovered. So this was a research done about 20 years ago by Professor Sadaf Farooqi. She works here at the Cambridge University in the UK. And her colleagues, they basically found that this absence of leptin or resistance to leptin is resulting in children who are becoming morbidly obese and severely hungry, basically, which we call hyperphagia. And that's what basically found that this is the pathway that's involved. And later on, it was discovered that there's other types of hypothalamic obesity involving the same neurons. And it's basically this pathway that has a lot of it has a lot of other inputs, and it has a lot of other associations which basically contribute to the mechanism, but this is the main pathway.
And it's interesting because there is then an integration between peripheral tissues, in this case adipose tissue, and the hypothalamus and the regulation of appetite. And there are other signals coming directly from the GI tract, right? So ghrelin and all
Absolutely,
this stuff.
absolutely, absolutely. And it's also interesting that while we have all of this going on and the hunger drive is being stimulated by leptin and ghrelin and all of these other things, it is actually still under control of the higher brain, of the conscious brain. So there's always that feedback, and then there's also the subconscious input from our reward centers. So that is what, that we say that people eat to feel good, because that is our body's natural pleasure seeking behavior, because of the activation of the reward centers in the brain. But it's all interlinked with the subconscious, the unconscious mind, and the homeostatic mechanisms.
Yeah, and this aspect of the reward system and how the metabolic and the hedonic mechanisms get together is very intriguing. So
Absolutely.
what is, biologically speaking, what is happening there? What is the connection between these two systems?
So basically, when we say that at the hypothalamic level, we know that all of these signals are affecting the hunger drive, right? So like I said, the leptin. So if a person has normal leptin levels, when they've eaten enough, this leptin signals the brain to say, okay, you need to stop eating now. And there's another section of neurons, the POMC neurons, which basically, so there's two sets of POMC neurons as pro-opiomelanocortin receptors. One set exhibits leptin receptors, which when they are stimulated by leptin, they activate glutamate neurons, some neurons which secrete glutamate, and they increase energy expenditure. And then there's another set of POMC neurons which basically express 5-HT2C receptors, which are our serotonin receptors, and they basically go and reduce food intake. Now, what happens is all of this connection is basically all of these interplay is fed back by the reward system. So if, for example, like we say, someone's feeling full, the brain is getting the message that, look, you need to stop eating, but the reward center wants you to eat more. So we keep eating more. But while the reward center can overdrive the homeostatic regulation to stop eating, our cognitive mind, or the conscious mind, can or they can overrule our reward center and say that, okay, no, actually this is not good for you, you need to stop eating now. So it's basically an interplay of all of those signals, where the cognition and the subconscious mind and the homeostatic mechanism, they're all integrated. And it basically does come down to some level of control, which probably, I think, at some point we think is out of our control, but it's there. At some level of control is there in people who don't have genetic problems, of course.
Yeah, that's absolutely clear. And as you say, there are some factors that are biological in nature, we could say unconscious, but at the same
Yes,
time, there are some other factors that can be under your control, even if not in a totality, at least partially, right? And we enter the
yes,
realm of the modifiable factors that can affect obesity. So those
yes,
those come even from the epigenetic level and extending to even social cues. So
yes,
let's start talking about epigenetics. How
yes.
can you modify that to affect gene expression?
So ideally, basically, lifestyle, how we eat, how much sleep we get, smoking, drinking, how, for women who are expecting, um, uh, you know, um, even what kind of food they're eating, all of these things affect the baby from such an early lifestyle, that these little changes in everyday life, from even if, as you mentioned in the article, like there are some things that we call endocrine disrupting chemicals, our use of unnecessary chemicals. We don't know how, but they do end up attaching onto our genome and resulting in minor changes in epigenetics, which just has led to this basically boom in obesity in our generation. We may think that, it's just, so I think a lot of patients that we see, they think it's just the food, it's just the exercise, but it's not. Anyone who's not getting a restful 8 hours sleep at night, anyone who's working shift hours, they have, too much stress that's leading to higher cortisol levels. That all of that, it basically is a type of epigenetic effect that it just does not allow your body to function properly and basically lose weight.
Yeah, and you touch on two aspects that are very important, and I want to emphasize. One of them is you mentioned that what happens with the mother is going to affect the offspring, right? And people may not be familiar
Absolutely.
with that concept, that that connection that extends beyond pregnancy. Can you tell us a little bit more about it?
So it's before I start specifically talking about that, I want to say that it's been found that the heritability of obesity is much higher than it was previously thought. And some people have found that, I mean, most patients that we see, they always have some family, first degree family relative who is always also overweight, and more than the genes, this has to do with the lifestyle that then, of course, as we said, affects the epigenetics. So with the mother, everything she's eating, her levels of stress during pregnancy, her, we all know the effects of smoking, taking any drugs. It's just this during pregnancy is basically the same. Her diet, her stress levels, basically they all contribute to the intrauterine life of the baby. And it's very interesting that even before the baby is born, even before they're eating what you're eating, you are affecting them by what you do. There was I think there was a study some time ago which found that the uh, eating behavior and lifestyle of young adults, even before they conceive their child, contributes to the children's overall health. So basically, people who were the study basically found that people who were overall during the time that they conceived and the time immediately preceding the time they conceived their children, how they led their lives affected the level of health in their offspring. And it was found that people who had a more healthy lifestyle had more healthy children, babies, even when they were born. So it's basically all of these factors.
And is only from the mother, or does what the
It
father
was
do
it
affect?
was paternal as well. Yes, it was both by the father and the mother. So so like for example with epigenetics, there was one research that found very interesting, is that the time at which a child is conceived, both parental experiences, um, they are inherited as epigenetic information in the child. And so I found it very fascinating. So this was basically not obesity related. This was basically how children can inherit intelligence and that is not just genetic intelligence. It's basically everything that they've acquired knowledge wise. And I think that that's probably the same thing at play here. So it's both the parent, the father, as well as the mother. Both of them contributed, because when, of course, we know the sperm and the egg carries genetic information. So that's how both of them are involved in this.
Yeah, and definitely there is then a transgenerational responsibility that we have, right? It's not affecting only us, but
Absolutely.
also the next generation.
Absolutely.
That's very interesting. I want to focus now on something that you mentioned in your paper. Obesity has traditionally been understood as an imbalance of caloric intake and caloric expenditure. And
Yeah,
it has been a constant fight trying to decrease the intake or increase the expenditure. But despite those efforts, the obesity numbers are going up and up and up. And probably we need to start rethinking the way we
yeah,
conceive obesity. So,
yeah.
what are your thoughts about that?
I think that, like you said, there's too much stress being placed on a calorie deficit. And what happens is patients often have conflicting information. They don't know what's working from them. They go from one diet to another diet. They end up giving up because, it doesn't work if it's not sustained. Now, what happens with a low calorie diet is because, our bodies are basically built for survival. The minute we get a stimulus, the body responds. So if we start eating a low calorie diet, yes, we will lose weight. A very low calorie diet, we will lose weight in the short term. But then the body has its response, and the body's response is to slow down the metabolism further. And there's only so much calorie restriction that you can do. So there has to be a basic understanding that, a, yes, you need to control the diet, but does it always have to be low calorie? Probably not. Low carbohydrate diet works for a lot of people because it is the carbohydrates that lead to the insulin resistance, and that is basically what puts in place the pathophysiology in the first place. But then some people find low carbohydrate something that they can't sustain for a long time. So they need to hit that balance where they think that they can sustain something for the long term. And I think for people who are doing a low calorie diet, they need to be with a professional, either trainer or dietitian who can guide them that, look, you need to, at this level, you need to stop taking this level of this number of calories at this point, or you need to increase your exercise to a certain point. So, how we can rev up our metabolism if it's slowing down is increase exercise, but it has to be strength bearing exercises, which then, of course, increase the metabolic rate. So it has to be, I think it's time sensitive. And everyone, and it's very interesting how people talk a lot about obesity phenotypes and metabolic phenotypes. I think there's potential for research there as well. But people need to find what works for them, and then they need to basically sustain that. So it has to be a lifestyle change. Going on a low calorie diet for 3 months and then going back to usual food intake, it doesn't work because it's not sustained. But then we need to start doing something which we can carry on in the long term. So perhaps have an overall low carbohydrate diet, maybe go out on the weekends and you can have one day cheat day or two cheat days. But I think that in whatever research that I've seen, the carbohydrate model is also something that has been spoken a lot about. Again, that the main driving factor for obesity is increased carbohydrate intake. And I think that is definitely what has driven the obesity epidemic to some extent, because we have the current culture where the cheapest foods are high carbohydrate. So of course, people prefer that. And then the yummiest foods are high carbohydrate. There are some cultures where the staple food is carbohydrate. I think when I was growing up, I realized, and when I had children, I realized that we were told that, if you don't eat anything, you can just have a piece of bread and you're fine, you know? So I think it's that thing that sort of the mindset is just shifted to the fact that, yes, predominantly carbohydrate rich diet, and then just eating in a way that probably is not very mindful. Other things. So if we combine it with fried food, I think what's happening is basically the uh, the advertisement companies are basically at play here. But I think the important thing that we need to do is to communicate to people what the actual culprit is, basically. And it's a combination of it's the eating pattern. It's not just the amount. It's the eating pattern. What are you combining with what? Fries with carbohydrates, no protein or no veggies. What type of carbohydrates? Is it low glycemic index? Is it high glycemic index? Even just adding a bit of fiber to our carbohydrate can slow the release of the carbohydrate in the body, and the interesting thing with carbohydrate food is it makes you hungry very quickly. So when we take something that's what we call simple carbohydrate, it's released in the sugar levels in the body rise faster. It gives us that sugar rush, and then the crash is deeper. So one of my consultants the other day was describing this as being on a roller coaster. So the higher you go, the deeper you crash, basically. And I think that's what drives the hunger. So I think even breaking the hunger pattern comes down to the carbohydrates. And this is something that a lot of people find hard to understand, because there's not a lot of talk about this out
Yeah,
there.
you are right. And actually the dietary guidelines in the Western world have encouraged a relatively high consumption of carbohydrates, and that
Absolutely.
makes things more difficult. And I think it compounds the whole obesogenic environment in which we are immersed.
Absolutely.
We have
Absolutely.
a sedentary life, easy access to low quality foods,
Yes.
and that's definitely contributing to the epidemics. And at this point, the access to information and understanding what you can do and what is the science behind it is going to help people. And I think you are doing a great job by communicating these aspects in terms of the carbohydrate load, lifestyle changes with good sleep, good physical activity, and everything put together is going to help. But there is also another aspect that extends beyond the individual, and is the socioeconomic environment in which you are.
Yes.
And I think that also affects the rates of obesity, right?
Absolutely. Absolutely.
So the what populations are more vulnerable in what you have investigated, and which ones are more prone to develop obesity?
So, of course, we know that when high carbohydrate or simple carbohydrate foods are going to be inexpensive, people who are struggling financially will end up going for those foods, and even for their children. So we know that the lower socioeconomic groups have higher levels of obesity. An interesting pattern that was seen in general research is that lower socioeconomic countries, when they had people who were moving from or becoming financially better, I think what was happening was they started gaining weight. And then, as opposed to this, people in higher socioeconomic countries, or first world countries, as you may call them, when people were climbing up the social ladder, as you say, or becoming financially more stable, they were actually becoming more health conscious, and they had lower levels of obesity. And I think it has to do with the culture, and it has to do with the awareness, because while people may know that yes, this is a healthy diet and this is a healthy way to live, they may not be able to afford it. But once they are able to afford it, they can go out for cycling, they can invest in activities which are more healthy. They're not always in that 9 to 5 run to basically earn money. But then in the lower socioeconomic countries, I think, I wonder why that is, but it's just that probably the culture and the level of literacy contributes a lot to whether knowing what's good for you or not. So of course, when people when they just when they are able to afford food, they just eat better, but it's not always what's healthy for them. So I think that was something that was found in research, and then of course that comes down to education and just awareness from a younger age as to what is healthy food and what's not healthy food.
Yeah, and there is also a combination of socioeconomic factors and some ethnicities that are more affected by those changes in different parts of the world.
Absolutely.
And some
Absolutely.
ethnicities are at high risk, and
More
we
pretty.
need. we need to pay
Yeah,
attention a little bit more to that to help, right?
that's correct. That
So
is
I,
correct.
and as you nicely put it, the obesity is multifactorial. There are factors affecting the genesis of and maintenance of the obesity disease. So when it comes to trying to find a solution, there is a certain level of individual responsibility in terms of lifestyle changes. There is also responsibility of the society at large. But I think it's,
Absolutely.
healthcare professionals play a significant role as agents of change. So what do you think
Yeah.
the health professional role should be to try to find a solution to this big problem?
I think that for people, for general healthcare professionals, not those specifically working with working in obesity, I think it's important to understand the need of the patient. So, if we have, of course, the patient who has obesity, he has a host of complications. He could have a cancer, which is a complication of his obesity, osteoarthritis, diabetes, high blood pressure, and so it could be any subspecialist, specialist who's seeing a patient with obesity. So, I think the most important thing to understand is what is the patient's need? Why did he put on the weight in the first place? What is his diet like? What is his social circumstances? How can we help him to achieve his goal weight? And I think a certain level of education it is incumbent upon us as clinicians to tell them that yes, they are here for their um, titration of their blood pressure medications, or they're here for their knee pain, but if we don't, as they don't always get the right information. And so as clinicians, it's important to tell them, look, you need to control the diet. We need to tell them, look, you need, it's 80% when we're trying to lose weight, 80% is the diet and 20% is the exercise. But then the exercise becomes equally important when we're on that path of losing weight to help improve the metabolic rate. So we need to tell them that, look, this is the problem. What are you eating? How often are you eating? What are you able to do? Even 10 minutes of walking a day will help you. People who have knee pain, for example, they say, oh, we can't walk. But we encourage them that no, at least even 10 minutes. So the patients who are bigger actually benefit more from even mild exercise, because they have, their metabolic rate goes up much easily when they're at a higher weight. So just explaining to them that, look, these are the things that you are eating is not right. Diets, you want to go on a diet, a very low calorie diet, is not sustainable in the long term. Start off with something that's more doable. We and teach them to teach their children, because uh, as we discussed earlier, the eating pattern is going to be the same. They will prefer carbohydrate foods for the children as well, and that child is becoming insulin resistant from a very young age. And I think that because this is becoming such a big problem, every clinician from every specialty needs to identify whether their patient needs help. So whether they, so now that we have so many medicines, we have the semaglutide, the GLP-1, receptor agonists, as we say. We have newer drugs such as tirzepatide. Then we have bariatric surgery. We need to identify the look at their. We need to identify them for what kind of intervention at an earlier stage, and we need to explain to them as well that despite the intervention, they need to change something. I mean, there's obviously something that they're doing, it has led to this, and that behavior needs to be changed. So one thing I saw in particular, for example, when we have patients coming in for um, asking for this injection that we call Ozempic. It's very famous. People have heard of it. So they think that if they take the injection, they're allowed to eat whatever. But ideally, the injection works only because it reduces your appetite. And if you continue to eat, unhealthy small amounts of food, you won't lose the weight. So it has to be both ways. And there was a patient who was saying, yes, I eat McDonald's for lunch every day, and I need the injection to make me not hungry to eat it. So it's I think it's that it's understanding that the drugs are not magic, the surgery is not magic. It will only be sustainable in the long run if you make an effort and a sustained effort. With the counseling, I think then we need to say, okay, what is this patient's BMI? So we have criteria for example, at a BMI of 35 with some complication due to obesity, for example, diabetes, hypertension, osteoarthritis, sleep apnea. Do we need, does this patient qualify for referral to bariatric surgery now? Yes. At a BMI of 35, with some complication, yes. At a higher BMI without complications, maybe if the patient is has now a BMI of 40 and he doesn't have any complications, even then we need to refer this patient because he's going to start developing complications very soon. So we need to start doing these referrals sooner. We need to start counseling them. We need to start identifying what kinds of treatment we can give them. We need to give at least something. So metformin, it's an off-license drug for PCOS to reduce insulin resistance in the UK, but it is licensed in a lot of places in the world. It's a cheap drug. It's good for reducing insulin resistance, and it helps with weight loss sometimes. So if there's nothing else that your patient is able to take and he's able to tolerate it, why don't you prescribe him some metformin if there are no contraindications? Talk to them about the other drugs that are licensed for use in your country and just suggest it to them. So if the primary healthcare provider can prescribe it for them, you can just suggest it, because people don't think about it and they don't do the intervention at the right stage, where and then becomes so much more bigger, and the patient keeps gaining weight, develops more complications, and then it becomes very difficult to control it at a higher BMI.
Yeah, you are completely right, and I think the complexity of obesity requires an interdisciplinary approach with a very active participation of the patient, like everybody working in the same direction, and that's an important message, and I appreciate the way you presented it. And before we close, I want to ask you about your research. What is coming next in the research that you are conducting nowadays?
So there's a lot of basically work on, because we have patients developing heart problems with obesity. We have them developing kidney problems, lots of cancers. So in the obesity clinic, we see that patients come in with a advanced heart failure, which is not attributable. There's no attributable cause for it, and then it's likely that the obesity has driven it. And so there's some study going on about how weight loss is whether weight loss is able to reverse these changes or not, because these obesity associated complications are imparting a significant burden on the healthcare system. So there's that, and then there's a lot of interest that I have in diabetes remission. So type 2 diabetes, as you know, probably is now classified as a reversible disease, and only about 14 even as little as 14% weight loss for some people can induce remission. So I think the point is to investigate how much of the complications are reversible, and for me personally, I'm very interested in exploring how effective intermittent fasting is, and time-restricted eating is. That they've been found to have a lot of benefits, and even positively affect the gut microbiome, that has now recently also been found to contribute to obesity. So they're all areas of research which I haven't pursued yet, but they're all interesting because, like you said, it's multifactorial, and every end, is a loose end that we can pick up and hope to get somewhere.
Yeah, and it's exciting to see what's coming ahead, and we are gonna be on the lookout for your research production, and hopefully we can meet again in the future to get an update about what you're doing,
Thank you very much.
and that way I want to close by saying thank you very much, Dr. Masood. It was a pleasure, and I think our audience is going to enjoy this discussion. The way you presented it, as I said before, and the kindness that you had with us, sharing your knowledge, we really appreciate it. Thank
Pleasure.
you so much.
Thank you very much, Dr. Rain.
Thank you. And for our audience, the link to the paper and the research that Dr. Masood is conducting is going to be in the description of the video. And don't forget to leave us some feedback. And if you have any questions that we can answer directly or Dr. Masood, please leave them in the comment section. See you in the next episode of Decoding Healthcare Research.